Good evening, everybody. Today's case presentation is about Myxedema Coma. So our patient was a 75-year-old female patient. She was a known case of hypertension, hypothyroidism, interstitial lung disease, ischemic heart disease, and CA medullary thyroid. Admitted to the hospital with the chief complaint of generalized weakness, body ache, cough, nausea since few days. Then the patient had reduced responsiveness, started complaining of breathing difficulty with drop in saturation. ABG showed respiratory acidosis with type 2 respiratory failure. Then when she came into ER, she had a cardiac arrest. CPR was given for 5 minutes and she revived after that and then shifted to ICU. CT brain was taken, which was normal. So on arrival in the ICU, her pulse was 87 beats, blood pressure was 125 by 78, respiratory rate was 22, saturation was 98% on PRVC mode with FiO2 of 40%. On head-to-toe examination, patient is intubated, mechanically ventilated, trial tube was in situ, DVT prophylaxis is given, CVS S1 S2 present. RS air entry was equal on both the sides. Per abdomen it was soft, non-tender. CNS GCS score was E1, VT M1, sedated and paralyzed. So based on this, our differential diagnosis was since she was a known case of interstitial lung disease, it could be acute exacerbation of ILD. Then cerebrovascular accident is the most common. Then our final and then our next differential was myxedema coma. Then, to rule out this cerebrovascular accident, we did CT brain, which came out to be normal. And then we have sent her thyroid profile. In that, TSH was quite high, which was 31. Free T3 was zero point 0.9, and free T3, T4 was 0.6. So clearly, this patient was in myxedema coma, and our final diagnosis was this myxedema. So we will have a brief discussion about myxedema coma. The term myxedema coma refers to a state that represents the extreme degree of severity of hypothyroidism. Mortality can be very high, therefore it is a true medical emergency, which deserves to be diagnosed and managed quickly and intensively. The pathophysiological substrate of myxedema coma lies in the intracellular decrease of T3 secondary to hypothyroidism, which causes hypothermia and cardiac depression. So when this occurred, the body will set compensatory mechanism such as chronic peripheral vasoconstriction, moderate diastolic hypertension, and decrease in the blood volume. But when there is some trigger factor like infection or any other trigger factor like myocardial infarction, stroke, then it will break that fragile equilibrium and patient will land up in myxedema coma. So up to 95% of myxedema coma cases occur in patients with primary hypothyroidism. Most commonly occurs in patients with hypothyroidism after abandonment of treatment. Less frequently, cases of myxedema coma have been described in patients who are not known case of hypothyroidism, in which multiple clinical manifestations can present a true diagnostic challenge. So what are the triggering factors? There are multiple possible triggers for myxedema coma, mostly corresponds to the situation of physiological stress. They have been described from cold exposure, stroke, heart failure, acute myocardial infarction, infectious process, sepsis, trauma, or fracture, and electrolyte imbalance. Decompensation of diabetes mellitus, such as type 2 diabetes ketoacidosis, hyperglycemic hyperosmolar state, are less frequent. The use of different drugs, especially amiodarone, anesthetic agents, and surgical procedure are another triggering points. So the clinical manifestation is patient will present with hypothermia. It is caused by decrease in thermogenesis resulting from hypometabolism, occurs in most of the cases and can go beyond 24 degrees Celsius. It has been considered as prognostic marker. Body temperature is equal to or less than 32 degrees Celsius. It is associated with higher mortality. Now the neurological alteration. The spectrum of neurological manifestations from the state of confusion, lethargy, obtundation, and even present seizure and status epilepticus. The etiology of this alteration is considered multifactorial, like could be hypoglycemia, hyponatremia, or hypoxemia due to cerebral loop perfusion. An entity called as myxedema psychosis has been described, which is characterized by behavioral alterations and aggressiveness. Now, the ventilatory alteration, weakness of respiratory muscle due to myopathy, obstructive sleep apnea, and mechanical obstruction due to microglossia. They present with the alveolar hypoventilation, hypoxemia, and hypercapnia, including requiring mechanical ventilation for prolonged periods. The cardiovascular alterations are like it is the main cause of mortality, bradycardia, hypotension, and decreased myocardial contractility and cardiac output. There is narrowing of the pulse with elevation of systolic pressure. Cases of congestive heart failure have been reported, however, because there is a decrease in oxygen demands. It is rare in the absence of persistent heart disease. Pericardial effusion is frequent. An entity known as heart myxedema is described, represented by hemodynamic alterations, cardiomegaly, electrocardiographic alteration, and enzymatic alteration like increasing CPK, LDH, and AST. The management of this manifestation focuses on hormonal supplementation, in some cases requiring inotropic support. On the gastrointestinal alteration, there is a decrease in peristalsis. Constipation is very frequent, which can manifest as myxedematous megaphobia. Myxedematous ileus can also occur, which is a gaseous distension of abdomen accompanied by a clinical obstructive abdominal syndrome. Renal alteration, it is the most common, most frequent finding in patients with myxedema coma, present in 43% of cases. In general, of multifactorial origin due to fall in cardiac output and hypoperfusion due to decrease in glomerular filtration or as a consequences of acute urinary retention. The presentation of acute kidney injury caused by rhabdomyolysis secondary to hypothyroid myopathy has been described. Now, the next is hyponatremia. It is a frequent electrolyte alteration secondary to multiple mechanisms. One of them is hyperproduction of ADH due to excess TSH with consequent water retention. It may also be due to concomitant adrenal insufficiency due to acute renal injury or being multifactorial. If it is a severe, it can contribute neurological deterioration, and if it is a mild, it has no clinical significance. Then the next clinical manifestation is hypoglycemia. It is present in 29% of cases. It may be secondary to hypothyroidism itself due to decrease in gluconeogenesis, a decrease in skeletal muscle glucose and adipose tissue, or it may be due to fasting and gastric varices. It has been considered a secondary to concomitant altered adrenal insufficiency or panhypothyroidism, panhypopituitarism. It has also been postulated that adrenal insufficiency is precipitated by stress and by rapid onset replacement therapy. It has been documented that women with the chronic autoimmune hypothyroidism, there is a relative risk of suffering from Addison's disease. Now, the myxedema being described as hard generalized edema, which does not leave fovea, and it includes the periorbital and acral area also. There is a supraciliary madrosis known as Queen Anne sign. The skin is cold and dry due to reflected cutaneous vasoconstriction, pale yellowish due to anemia, and hypercarotenemia and rough to touch. Now, the electrolyte alteration, frequent electrolyte alteration secondary to the multiple mechanisms. One of them is hyperproduction of ADH due to excess TSH with a consequent water retention, although today it has been questioned. Now, it may be due to concomitant adrenal insufficiency to acute renal injury or being multifactorial. If it is severe, it can contribute to the neurological deterioration. If it is mild, it has no clinical symptoms. Then there is a diagnostic criteria, diagnostic scoring system for myxedema coma. The Glasgow Coma score based on GCS, if it is a 0 to 10, then 4. Then 4 points. Then if it is 11 to 13, then 3 points. If it is a 14, then 2 points. If it is a 15, then 0 points. Based on TSH value, if TSH is more than 30, then 2 points. If it is 15 to 13, then 1 point. Then if it is based on T4, if it is a low T4, it carries that is less than 0.6, it carries 1 point. If there is a hypothermia, that is temperature less than 95 degrees Fahrenheit, then 1 point. Then bradycardia, if it heart rate less than 60, then 1 point. And precipitating event carries 1 point. Now the total score, if it is more in between 8 to 10, then high myxedema coma is most likely. We have to treat accordingly. If it is 5 to 7, then it is likely, and if it is less than 5, then there are very less chances of myxedema coma. The treatment. Now the treatment part, the goal regarding myxedema coma management should be aimed at improving neurological, cardiovascular, and pulmonary manifestations. So the management in the intensive care unit should be provided and remain under monitoring of the cardiorespiratory status, receiving ventilatory assistance, and effective water resuscitation in correction of hypotension and electrolyte alteration. It is recommended to initiate passive rewarming, since active rewarming could generate peripheral vasodilation, generating cardiovascular collapse. The identified trigger must be investigated and treated. Now, the L-thyroxine, the first synthetic molecule used for the management of hypothyroidism, remain the mainstay of treatment. It is suggested to start with the initial loading dose of 300 to 400 mg, always if possible intravenous. Subsequent supplementation should be continued with 1.6 mg per kg or 75% of the doses in case of IV administration. This being the ideal route, due to the base clinical and the paraclinical results shown in the short term. The enteral route is less preferred due to alteration in the intestinal absorption that the patient have, as well as the need for immediate bioavailability of thyroid hormone. Taking into account, in most of the cases, myocardial coma, myxedema coma patient present with the peripheral conversion reduction. The adjunctive therapy with the compounds, we should always give in combination like T4, T3. It is also preferred to use it intravenously and administer it at low dose. Since it has been documented that dose equal to or greater than 75 mics per day are associated with the higher mortality. At initial dose of 5 to 20 mics is recommended, followed by the fractionated doses at rate of 2 to 5 mics, 3 times a day, continuing at least until significant clinical improvement is obtained. Glucocorticoid supplementation is indicated empirically in all cases at the dose of stress. So the before starting supplementation with levothyroxine and having previously requested plasma level of cortisol. It is recommended to initiate hydrocortisone 100 mg intravenously followed by 50 mg intravenously 6 hours. It should be continued until concomitant adrenal insufficiency is ruled out. Now the prognosis. The prognosis is becoming better with this emergency. So it has been identified that best predictor of the poor prognosis are deterioration of the level of consciousness, Glasgow scale equal to or less than 5, and the score equal to or greater than 20 for Apache. More recently, it was shown that SOFA score is more effective than the other model. So a score of 6 point at the beginning and at day 3 is highly predictive with the mortality greater than 60% from this cutoff, which increases by increasing the score. Thank you.